Good afternoon, everybody. Welcome to the 2022 webinar series. We will start with a EUPSA webinar in collaboration with the eUROGEN. And we picked a very interesting topic, I think, cloacal extrophy, a very rare disease that none of us have a lot of experience with. And we have the privilege to have Professor Thomas Boemers from Cologne tonight, and Professor Ivo de Blaauw and Professor Wout Feitz from Nijmengen, Netherlands. We run these webinars series on a monthly basis, always at on a Wednesday at 4 p.m. And we're doing these webinars together with Professor Augusto Zani from Toronto, who will introduce himself later also. And I think we can just jump in the middle of things. We have 111 people online. Those who could not make this meeting, afterwards this meeting is video edited, and then we put it on the EUPSA YouTube channel, and we put all these links in the chat later. I think we can start with the first speaker, which is Professor Thomas Boemers. We do a very brief introduction. Professor Boemers is Associate Professor of Surgery at the University of Cologne and the University of Tübingen. After medical school at the University of Munich, he underwent surgical training in Lübeck, Munich, and Utrecht. And he's board certified not only for pediatric surgery, but also for urology. In 1997, he then worked as a staff surgeon at the Hamburg Children's Hospital and the University of Tübingen. Between 2001 and 2005, he was chairman of the Department of Pediatric Surgery at the University of Salzburg. And since that time, so for the last 17 years, he has been surgeon-in-chief at the University of Cologne Children's Hospital, which is among the biggest departments in Germany. Ever since, Thomas Boemers had a clinical and scientific interest in colorectal surgery and urology. He's a true expert in the field and well known for taking care of children with very complex pathologies. So, Thomas, it's both an honor and a pleasure to have you with us tonight, and we are looking forward to your talk. While Thomas is uploading this, if there are any questions, you just put them in the chat right away, and we will answer all these questions in the end. After the second presentations, we will read out your questions and then answer them. So Thomas, you should now share your screen. Okay. Looks perfect.
So I would like to give an introduction on the treatment of cloacal extrophy. And actually, since I had COVID, I was not able to access my PC at my office in the children's hospital. So I had to take what I had, and this is actually a presentation which is quite old, but it's not bad because it shows some things I said 10 years ago, which today maybe I wouldn't do anymore, or at least I would discuss. I just have to get a chair, just a second. Okay, so this is Children's Hospital of Cologne, and what the outline of my lecture is, first of all, I would like to give a background of cloacal extrophy, then tell you what actually is cloacal extrophy, because it's very rare and not every pediatric surgeon or pediatric urologist has encountered this entity. And then I would like to discuss common problems, the management of cloacal extrophy, and last but not least, discussion points. Children's Hospital of Cologne traditionally is a center for children with anorectal and cloacal malformations. And so we see a vast number of children almost weekly, and especially children with cloacal extrophy. So for whom hasn't seen it, this is a typical picture of a newborn child with cloacal extrophy. And we in Cologne see about 4 to 6 new cases every year. This year we have already seen 3 cases of cloacal extrophy. And more or less we have, of course, we can tell you a lot about the management problems in these children. Now, my personal experience from 14 years is 62 patients, of whom are 44 boys and 22 girls. Of the girls, 6 children had originally or have an XY karyotype, which is something we have to talk about later. There were 17 primary cases and 45 secondary cases. And at the present, I would say we treat at least more than 38 children regularly with cloacal extrophy on a regular basis through follow-up at all age groups. Some historical remarks. The first description was done by a French anatomist, Alexis Littré, who described cloacal extrophy in 1709. A German anatomist, Johann Meckel, which you all know from Meckel's diverticulier, was the first one to actually give an anatomical description of this entity. And another German anatomist, Ernst Schwalbe, he called the entity vesico-intestinal fissure. Later, especially in the American pediatric surgical community, the name cloacal extrophy was introduced, and actually we use this until today. The first successful treatment of 4 patients with vesico-intestinal fissure was Peter Paul Rickham, a well-known British pediatric surgeon who worked in Zurich, Switzerland. And from 1978 on, Carey et al. Coined the term or acronym OES complex, which is omphalocele, extrophy, imperforate anus, and spinal defects. Actually, this is widespread among prenatal doctors. And when they refer a child to me, they usually talk about OES. So the incidence varies. Sometimes it's 1 in 200,000, sometimes it's 1 in 400,000. So I took 1 in 300,000. Actually, we do not really know because we do not know how many pregnancies are terminated. And so the true incidence, in my opinion, is not clear. When it comes to sex, boys and girls are almost equal. In our group, we have more boys. In the literature, sometimes there are more girls. Anyway, so in my opinion, it's more or less 1-to-1. There's one thing which is very interesting, and that's there seems to be an association with monozygotic twinning. Fullerton described this in 14% of cases, and we also see this very often. Interesting enough, sometimes both children are affected, but very often only one child is affected with cloacal extrophy. Spectrum is a high variability, and prenatal diagnosis can be done in 100%. One of the main features is the elephant trunk deformity, which is actually the proliferating ilium, which prolapses through the cecal plate. We do not know a cause, and embryologically, we also are still stuck with a wedge effect described in the 60s by Marshall and Mücke. Now, the general problems are continence for urine and feces, fertility issues, sexual dysfunction, orthopedic problems, neurologic problems deriving from spinal anomalies, and of course, psychosocial problems. Now, this is a typical picture of a classic cloacal extrophy. And just get me my laser pointer on. And you can see this is the main feature, the cecal plate with a prolapsing ilium. There's an omphalocele cranially, and there are almost always two bladder halves, extrophic bladder halves, and then we have a tail gut. And this is what it looks when you see a newborn child with cloacal extrophy. So this is the omphalocele. You have a right extrophic bladder plate, the left extrophic bladder plate, the cecal plate, which is also not closed, and the prolapsing ilium. And most of the children have a split genital. In this case, it's a boy, and you can see there's a hemiphallus on each side. And of course, we have a wide spreading diastasis of the symphysis. And this is what the same child looks after successful primary reconstruction. So when it comes to the urinary tract, usually the extrophic bladder is in two halves, a bipartite bladder extrophy. Of course, many children have renal anomalies, upper tract anomalies. And usually there's always genital hypoplasia of different degrees. The corporal bodies in boys is almost always split. However, there are some cases with the midline phallus, which is usually very foreshortened. And also the clitoris is split in girls. Then we have vaginal anomalies with shortening, duplication, and of course, duplication of the uterus. Split symphysis is present in 100% of cases. Almost all children have spinal anomalies. However, the severity differs, and almost all children are able to walk. There are only very, very few children who are wheelchair bound. And of course, some children also have anomalies of the lower extremities. Then what we see is that concerning spine anomalies and anomalies of the nervous system, we see lipomyelomeningocele, myelocystocele, and tethered cord in 100% of cases. When it comes to the gastrointestinal tract, imperforate anus is always present. We usually have a foreshortening of the intestines, not only of the large bowel. Here you can see a typical tail gut, which is a rudimentary colon. This is the reconstructed extrophic cecal plate. But we also have foreshortening of the small intestine, which is important when you do reconstruction of these children for bladder reconstruction. So when you treat these children, you have to be aware that it's very, very difficult, especially when you treat children who were operated elsewhere previously. You have a lot of adhesion, bowel adhesions, and these children are prone to a lot of problems once you operate them. So you have to have a good management plan from the start on. So what do we do when we have a newborn or child with cloacal extrophy, or what do we recommend? First of all, stabilization and evaluation. Keep cool. Information of parents, doctors. Doctors are able, have enough time to consult centers where children with cloacal extrophy are treated on a more common basis. You can consult with experts. You can involve parent support groups, which is very important. And you can make a management plan and concept. Do not rush with operating these children. In older children, the management, of course, depends on what already has been done. There are different approaches. because of the high variability of the anomalies itself, or what has been done in by other doctors or in other different hospitals. So one very important thing is cloacal extrophy, or newborns with cloacal extrophy do not pose an emergency. You do not need to operate these children within hours or days. So you can, what we do, we put a tegaderm on the defect, no gauzes, because this will irritate the bladder and the cecal plate. And children, when they are born in another hospital, they can just be transferred like this. No rush is necessary. This is actually a child which was born with cloacal extrophy, but which I saw when it was 1 year old, untreated, and it survived without an operation. You always have to think that the prolapsed ilium is just like a prolapsed ileostomy, nothing else. So what about gender issues? There should today be no gender conversion in boys. This has been done widespread in the 1970s, and because it was thought that the genital defect in male patients would not enable them to grow up as a male. And so widespread gender conversion was done in these boys. Today, it has a lot of legal implications. Actually, in Germany, by law, you would not be allowed to do it, even if you would like to, or if the parents wish so, it would be impossible. And the thought, there is no doubt these boys can be made into nice little girls, which was cited by said by a very famous surgeon. The real question is it true? I mean, these both are pictures show boys which are converted into a female sex, but I wouldn't say you can speak of nice little girls. So even surgery in expert hands doesn't lead to a very good success. The genital defect in boys can be treated. Usually the split halves can be conjoined in the midline, and you can create a small but central phallus. In girls, usually the uterus is doubled, and more or less all female children with cloacal extrophy need vaginal substitution. And pelvic osteotomy, if you operate older children, is usually inevitable. What we do is anterior innominate osteotomy. And you can see this is the symphysis. The cecum has already been reconstructed, and to close the bladder, we performed iliac osteotomy, and this is the result following the operation. When it comes to continence, we should always plan for full social and urinary continence in these children. 2 bags, I think, is not what we are looking for. And the question really is, what do we have to do with the bowel? Should we reconstruct it? Today, I have different thoughts on that. Years ago, I would have said, yes, we should perform a pull-through in all patients and see whether they can become socially continent with bowel management. So I think it's too much if I go through our results because they are not valid anymore today. However, we should keep in mind it is possible to create social continence concerning fecal continence in children with cloacal extrophy. And in every case, we can achieve or attain continence for urine by creating a neobladder with continent catheterizal stoma. So all in all, cloacal extrophy is a very complex malformation affecting multiple organ systems. Re-interventions are always necessary. Reoperations and complications are very common in these children. Management should be performed in specialized centers. Social continence can be achieved, especially for urine in all cases and for feces in some cases. Gender coherent reconstructions are mandatory today, and social problems should be managed proactively. And these are my discussion points. What we should discuss is the usefulness of intestinal tract reconstruction. Should we reconstruct the cecal plate for the intestine, or should we maybe use it for bladder augmentation? Is an ileostomy per se always bad? Preservation of uterus, is that useful or not? It would depend on whether or not there are any case reports of female patients with cloacal extrophy who were able to mother a child. And is vaginal reconstruction mandatory? Because, to be quite honest, in most cases, it does not work. So this is the end of my lecture and the discussion points. Martin, maybe you have to start with the discussion.
Yeah, thank you very much, Thomas, for the beautiful talk and very nice overview and illustrative images. Before we start the discussion, we will have our second speakers of tonight, and then we will jump into the discussion. So
before any further ado, it's my pleasure to introduce both Professor Dr. Ivo de Blaauw and Professor Wout Feitz from Nijmengen in the Netherlands. I'll give you a synopsis of what they've done in their career, and the accomplishments are many. Professor de Blaauw was actually both Professor de Blaauw and Professor Feitz went to medical school in Radboud University in Nijmegen in the Netherlands. Professor de Blaauw, I discovered that you, in your early career, you did some global surgery, as we call it today, with an interest in tropical medicine, and you worked for Médecins Sans Frontières, which is something very interesting. Of course, we know about your early research on amino acid and protein metabolism in cancer. You worked in several centers in the Netherlands, including Eindhoven, Maastricht, Nijmegen. But since 2014, Professor de Blaauw has been the head of the Pediatric Surgical Department at the Amalia Children's Hospital in Nijmegen. His research spans from colorectal surgery. He's an expert in anorectal malformations, Usefulness disease. He's very he has done research, also basic science research, with which includes genetics of anorectal malformation and the pathology of Usefulness disease. But this goes beyond his interests. Also are in traumatology, pediatric critical care medicine, and CDH, in fact. Professor Feitz, as I said, also studied medicine in Nijmegen. He specialized first in urology and then subsequently in the field of pediatric urology. In 1993, was appointed as a pediatric urologist in the Department of Urology at the Radboud University Medical Center in Nijmegen. In 2001, he became associate professor, and since 2006 has been a full professor in pediatric urology in Nijmegen. He is the representative of eUROGEN's HCP network coordinator for the Nijmegen University. He's an expert in cloacal extrophy, and so we are looking forward to hearing your experience combined on the colorectal and urological side of this complex congenital anomaly. So I give you the microphone, so Ivo, you can share your screen. Thank you.
Thank you very much for these kind words for both of us, and greetings from Nijmegen, the Netherlands. And thank you, Thomas, for a beautiful overview. It seems we had a good connection because there's not much overlap, I think, with the presentation Ivo and I prepared. I'll start a little bit concerning the webinar and our experience, which we published in 2014 of our 20 patients, and some new recent developments. So thank you for inviting us. Thank you for this very difficult topic. Like you mentioned, you could discuss the whole day. We will keep it to 20 minutes and then some discussions, and probably in 1 or 2 years, we'll have to repeat this. I think from Nijmegen, the Netherlands, we are one of the expertise centers for rare diseases in the Netherlands, which are now officially recognized through the Ministry of Health. We have a long-term care program for patients with rare diseases, which all need, of course, multidisciplinary care teams, depending on their life cycle and period in their life, and with lifelong care. And we are one of the ERN, European Reference Networks, EUROGEN for urorectogenital anomalies, and a member of this network, which now involves more than 56 hospitals from 20 European member states. Just to give a little bit about this program, it's a program started originally by the European Commission about 20 years ago, slowly developed, but put into all legal requirements of the European Commission. And the best thing is this, that they want to have a better care for all patients in Europe. For rare diseases, this involves about 30 million patients, and worldwide, this involves more than 300 million patients. The part which is very interesting for all of us is that this is funded by the European Commission, at least the coordination and management, and very special separate actions. And currently we have a funding budget visible up till 2027. So we expect that these structures will not disappear. Of course, there's always a conflict of interest, but we try to work together in the best way possible, where we share the information, the care programs, cure when possible. And like I mentioned, it's funded by the new EU for Health program. Now, this involves at this moment 24 European reference networks, which overall involve about 1,600 medical teams for all different rare diseases. Now, for EUROGEN and the congenital anomalies, we work closely together with Ernica and some of the other ERNs like Ithaca on spina bifida. What does this involve? Well, each hospital has agreed to participate in the different developments: harmonization of disease management, monitoring, reporting their patient numbers, promoting the research, online disease information, training like these webinars, and virtual consultations. And on different levels, progress has been reached already. We have a close collaboration with the EUPSA, with the ESPU, with the EAU, with ARMNet in Europe, and other scientific societies. So we try not to do work double, because everybody is busy. We try to keep things organized so that at least we can prevent double work. Our structure at the moment involves 36 orphanet-coded areas, over 120 diseases, and in 3 work streams. So one is on congenital urorectal anomalies, second is for functional urology, and third is for rare urological tumors. And in these, we have a collaboration between the areas of bladder extrophy, cloacal extrophy, and anorectal malformations, of course. And like I mentioned, we work closely together with some of the other experts from other networks. Now, one of the things which was developed through this is, as an example, through the patient involvement, because on all levels, we have patient representatives, was the development of patient journeys. So not only one item, one surgical procedure. No, how is their life going in the future? And which steps can they expect? Which are the common needs for these patients with a rare and complex urogenital anorectal condition? And where should we think about which might not be in your forefront of the brain? Now, for one example, for the psychological aspects, there are also common challenges in uncommon conditions. We recently had a webinar on this, and for those who are interested in this, I would like to refer to the website of the eUROGEN, where you can find these webinars and have a look at it. So it's not only the surgery, it's of course also the functional problems, self-image, and like was mentioned, sexuality, multiple comorbidities, and like I said, the psychological support, not only during childhood, but also later on. Now, if we look at our own experience, I think in Radboud University Medical Center, we reached about 50 years of care for patients with a cloacal extrophy. And in 2014, we published, say, the first 20 patients over a period of 1974 to 2013. Most now will survive, although some patients might die, and in certain centers, they might even advise to not treat these patients. We always think that a second opinion in these cases should be offered at least, because it's a difficult and it's very much depending on how you tell your story to the parents and what is the reality later on in life. I think, again, you need expertise centers, as was stressed by Thomas Boemers and many of the ones who are in the webinar participating. It's long-term care, so the hospital should be aware of this, and the management of the hospital should be aware of this, and it might be a lifelong contact point. We should remember that multidisciplinary care teams change due to retirement, change of workforce, and other reasons. And we hope that with the new networks and new registries will provide additional knowledge, future experts, and multidisciplinary team member trainings, and exchange by a supported exchange program of experts, but also the members of a multidisciplinary team. So also nurses or psychologists could travel to another network center. Now, if we look closely at our publication, like I said, it was published over a long time because many of the people involved, some were already retired. So we found a student who finally wrote this up after a couple of years. And already, if you look at all departments needed, it's the surgery department, the pediatric surgery department, urology, endocrinology, psychology, orthopedics, obstetrics, neurosurgery, neurology, and we might even have forgotten somebody. It's not only the doctors and surgeons, it's also the nurse specialists, and we'll come back to that later. And everybody actually, which is involved with the parents during their stay in the hospital, but also as a contact point when they're going home. If we look at our results, we agree with Thomas that gender reassignment discussion should be whole, because still some people think that there might be a place for this. If we look at our 20 patients, we also had patients who had male reassignment to female, but we changed this a couple of years ago. So if we look at the new roles of the patients, and especially the older patients, I'd always tell them, you're the teacher for the new doctors. Don't forget this, because many doctors you might encounter will not know what a cloacal extrophy is or which problems you have and why you have these problems. So there are multiple experts needed, special facilities, multiple organ systems, as was mentioned, involved, not only at birth, but also later on. In my experience, many patients find their own way and their own consults when needed. And like I said, we hope to improve or innovate at least the care and the support for these patients through the new networks, which also have a better funding than was ever available in my view at least, for these kind of patients or our specialties. Just to mention one case, we had a case who was had a gender reassignment, but during his life, at the age of 15, he chose to be a reassigned person. And this is, I'm still seeing this patient. It's a huge change, but still he will need at several levels by several experts support. And since 1998, we changed this policy in our hospital, which was not so easy because you needed an independent chairman and then some rounds of discussion before everybody could agree to the change of this policy, which was there for quite some years. So the conclusion from these patients is that you need multidisciplinary teams. It should also be clear for the hospital and the hospital management that you have to train new staff in time before the ones with more expertise is leaving. And these patients need not only during their early period in life with their parents, but also later on at least contact points where they can reach, where they can discuss new problems, and new experts have to be found to help them out. Now, currently, our patients, most patients are older and arrange their own life and follow up. Mostly, there's no problem, in my view, with the bowels when they are older. 3 patients, however, need urological care because of kidney stones or bladder stone. 1 patient underwent a revision of a urinary diversion, which can be due to the growth during puberty of the abdominal wall and exercise. And some patients, it's good to realize they are in adult follow-up for a urinary diversion or a urinary reconstruction, but do not disclose the origin of the cloacal extrophy. So they don't want to know, that doctors know what are the underlying diseases actually. Now we go to a small discussion part from Ivo.
Thank you very much. Well, it was said that by the time the patients grow into be in adulthood, there's generally not very much issues with the stoma or with the pull-through. It's more or less balanced. There may be some changes, but from birth till that time, there are a lot of things happening, and there's a lot of discussion how to manage the hind. And Thomas already mentioned it, and I will try to focus on it a little bit more, particularly because pediatric surgeons are will be involved when dealing with cloacal extrophies. Of course, I have no conflict of interest if you talk about it financially, but there are, of course, other conflicts of interest always at any time. This has been discussed with by Thomas before, the omphalocele extrophy of the bladder, imperforate anus, spinal anomalous complex, or sometimes you read about, they call it a syndrome. It's one of the rare diseases in the rare disease. Thomas mentioned it. We don't know the exact incidence or prevalence, but if you count all the stillbirths, it is estimated to be 1 in 10,000, and the live birth is more or less 1 in 200,000, 1 in 400,000. This means that it's been estimated, like in the United States, there will be about 20 patients per year. The reason for telling this again is that I think we need some kind of centralization of care. We all somehow agree that not everyone should be treating it. You should, in regions, you should seek for expertise centers. That's one of the reasons that the reference networks was built up as well. There is a male prevalence generally in literature, but Thomas already said it as well. If you look more closely and counting the stillbirths, it may be even a 1-to-1 ratio as well. We think from day one on, it is multidisciplinary. So when you see a patient, when you want to treat a patient, I think you have to be prepared for a multidisciplinary approach. And this multidisciplinary approach is in cause. I think if you do research, it is in care, cure, when possible, and share. And care, cure, and share are the mottos of the reference network as well. And cure is indeed where possible. And here you can see the multidisciplinary. Again, Thomas has shown you as well, but maybe we can go through it a little bit more. You have the cecal plates with the ilium, like an elephant trunk, where you see on antenatal diagnosis. You see the split bladder, the two bladder halves, the omphalocele, which is generally for the surgeon. You see the kidneys. There's the spinal anomalies for the neurology, for neurosurgeons. And you see the hind gut, and that's what we'll talk a little bit more about. And the hind gut is generally at a median length of, most patients have a hind gut of a median length of 10 centimeters, which is not very long. And I'll get into that later on a little bit more. So I want to take you along with an imaginary patient. So imagine a patient, a female patient, and we'll discuss some items on the hind gut, talking about this patient. Female patient, 5 years, referred to you or to me or to anyone, born at 35 weeks with an antenatal diagnosis of cloacal extrophy. And at day 6, a pelvic osteotomy was done. The omphalocele was closed. They saw a malrotation, or a lapse procedure was done. It was a double Müllerian system of uterus, vagina, and the cecal plate was detached from the bladder with the 2 appendices from the bladder. It was tubularized and reconstructed, and a loop ileostomy was made, and a colonic fistula was made, a blind ending colonic fistula. The bladder was closed at the primary stage, and there was a reconstruction of the vaginal opening with the bladder neck and as a urogenital sinus. So there are 3 more items concerning this patient that could be of importance. First of all, she had a spina bifida and a tethered cord, which was treated with effective management. She had a dysplasia of the hip, which had an open reconstruction. And now we get to the bowel. The bowel was 66 centimeters, the colon 8 centimeters. And she was on parenteral nutrition for 2 to 3 years. So looking at these patients, what about the hind gut? What are the items that we see about the gut and the hind gut? First of all, in this patient, you see she had intestinal failure. She was on TPN, and after 3 years on pre-digested nutrition, but she had intestinal failure. She had an ileostomy. Is this related? And she had a colonic fistula, which was blind ending. Now you have to think that that's our policy, that many of these decisions, whether you want an ileostomy or colostomy or closure of one of them or pull through, are decisions that need to be made in time, and not by the surgeon, the colorectal surgeon on his own, but it's done with the neurosurgeon, with the urologist, with anybody involved. Could be a psychologist, could be the pediatrician. So we sometimes change our policy as well from ileostomy to colostomy or whatever. To get a bit of view of what happens, and I think Thomas already mentioned it as well, what is our role as pediatric surgeons as birth? Stabilization of the newborn is the first item. We don't do it ourselves. That's the NICU or the PICU doctor generally is concerned with. But you have to be sure that the patients are stabilized. Like Thomas says, you don't rush to the OR. We have to protect the exposed organs, the mucosal surfaces. Don't use gauzes for the bladder, but use celastic material. You different material you have it, but prevent evaporating losses. So that's your first concern. And then you plan the surgery, and it's a multidisciplinary approach again. Be prepared. I think you should be prepared if you get your first case, or be prepared to refer the patients. You have to have your disciplines ready if a case comes, or have to know where to refer the patient to. And surgery is in our clinic generally done between 48 and 96 hours, could be longer as well, particularly if you have our experience with bladder extrophy, can be longer, but this is more or less the time that we try to plan our initial surgery. And when you start at this 96 hours, what is then our role as a pediatric surgeon? And kind of differentiating between pediatric surgery and pediatric urologist. First of all, and we discussed this as well, the gender needs to be assigned. It is generally because they are antenatally, most of them are diagnosed, there is a karyogram, otherwise you should know. Gender reassignment is not done in our clinic anymore. This New England Journal article published by Reiner has clearly shown that approximately 50% of the patients with a gender reassignment were having male type of behavior and were unhappy with their gender reassignment at birth. So we have closed this chapter with gender reassignment, but I know from literature that, and some conferences, there's still discussion that some people are thinking about it. And Thomas said it, in Germany, it's illegal, and the European law, I don't exactly know, but it is very difficult. But you should know the gender before you start the surgery. So again, it is, for us, it's an individualized approach. We have to know the patient, and we need surgery, urology, orthopedics, anesthesia, and ICU, whether it's pediatric ICU or neonatology, on board. Sometimes you need neurosurgery as well, but generally this is not needed in the beginning. So what is the procedure about? I think Thomas said something. We always do an iliac osteotomy. Not everybody does it, and every time I think in all cases we do it to close both the abdominal wall and the bladder. We do an excisional omphalocele, and this is more fat. If you look at it, the slide, it's more clear presented what the role is of the surgeon, but the excision of the omphalocele, maybe treatment of the malrotation, and then separation of the cecal plate from the bladder. We try to tubularize the cecum and make an end colostomy or an ileostomy, and I'll get to that later, what and when we do, what the discussions are. We close the abdominal wall, and then we have a bladder reconstruction, either primary or stage, and we have a genital reconstruction, and this can be staged as well. So let's go back to our patient. What about the hind gut? She had intestinal failure, ileostomy, a colonic fistula, which was blind ending. So at the initial surgery, the fate of the hind gut can either be an ileostomy and a resection of the colon. This was done in the past, and I think more or less until the 70s and 80s, but it was then clearly shown that the colon had some value. So it's not performed very often, but still can be one of the options you have if there is hardly any good colon. An ileostomy can be done with a colonic mucous fistula, which was done in our case, or you can do a cecal tubularization with a colostomy. After the colostomy, you can always choose, and that's another thing you have to think about, will I stay with the stoma, or will my patient be better off with a pull-through? Now let's go through this as well, and also to some experiences. This is the first one is the Baltimore experience, which is a large center. And you can see on the left side of the slide, and they published in 2010, 44 years of experience, 77 patients, which is a large series. In which one of the things you can see that the ileostomy has gone down, and they made a lot more colostomies. Another thing, what you can see, that a large group have a small length of the hind gut. So the hind gut is, for 2/3 of the patients, between 0 and 10 centimeters. And they did 30 and 47 ileostomies, half and half, more or less half and half ileostomies, colostomies, and 8 times a pull-through when the patient could make solid stools, and if these patients had minimal spinal anomalies. If we go to a more European publication from Gosh, we see in 2009, 18 years of experience, 9 patients. So the series are often not very large. 8 times a colostomy, 1 time a pull-through, revised to ileostomy. And although all these colostomies had more than 60% had serious complications, they clearly prefer to always give a colostomy and not do a pull-through. If we then go back to America again, in 2008, it was Mark Levitt and Alberto Peña who published a series, and this was of cloacal extrophy of 53 patients, but finally 20 patients were evaluated for a pull-through, and they went to a bowel management program. So they need to have solid stools and a bowel management by the stoma, meaning that they should be cleaned by the stoma. And it was a very nice program. And then they had a very high success rate in which 85% was clean. So there you see that, particularly in some groups in America, it is thought that the pull-through is much better than the colostomy. So what about us, I would say? How do we think about it? I think we're more or less in the middle. First of all, we published, like Wout says, we published our series, and this is 20 patients. And what I first like to show you that the hind gut, we see a lot of, and everybody does it, duplications of the colon, duplications of appendix. The hind gut is actually not normal. Another thing, what I'd like to focus on as well, and this is not the hind gut, that 4 of these 20 patients had a single kidney, but also a large group had dysplastic kidneys, meaning that it's not all about how you do the main thing is not the hind gut or the colorectal issues, but you have to communicate very much with urology on how to deal with these issues, because they may need some bowel, they may prefer a colostomy, and then it's better to stay with the colostomy. In other cases, it can be preferred to have a pull-through. Now, what we also saw is that the median length was 9 centimeters, not very large. And there were 3 patients with a very small colon. And we don't think they are the preferred patients for a pull-through, for example. So if you look at our series on outcome, we see that we had 5 patients with a pull-through and 2 were converted to a colostomy and ileostomy again. So we ended up with 3 patients with a pull-through, of which 2 were continent and 1 was pseudo-continent. So looking at that series, it's very good if you look on those 3 only. But the majority did get a colostomy and did get an ileostomy. The reason for us to do a pull-through of a colostomy is only when they have solid stools, they have sufficient pelvic floor muscle, and this is to be judged at surgery, at the first surgery or an MRI, but you have to have some opinion about it. And we think you need to have minimal spinal anomalies. Going back to the case, we did a laparotomy and we looked at the colon, the fistula, and we found 10 centimeters of ilium and 23 centimeters of colon, attached that to the ilium, and she ended up with an ankylostommy. And there were no complications, not much adhesions, luckily, and she recovered very well. And the stools came out, the stoma, for the first time, not so watery. It helped her with her, what we call intestinal failure. So we were happy at first, but not after 3 months, because then the colon became kind of dysfunctional again. The stool was watery. This colon, this piece of colon was kind of obstructive with overflow of small bowel content. So it was either empty and sometimes loose stool came out, sometimes good stool came out. It wasn't easy. And we made an X-ray. We did an endoscopy and we found non-specific inflammation. So this bowel was not really very perfect. So at the moment, we are treating her with conservative treatment. Anti-inflammatory medication was given, probiotics, antibiotics, water-soluble fibers, and it's stable now. And she has a nice solid stool coming out. She's doing fine. However, this is 2 years later. We are still thinking about resection of the bowel. because it's not a perfect bowel. If it was going to be perfect, we may consider, and if she produces solid stool, are we going to do a pull through? I don't think we urge or encourage people to do so. But I can imagine, like if you live in another country, that it might be encouraged more. Another thing you have to think about, we can use this bowel for reconstruction of the bladder vagina, but if it's easily inflamed, would you want to use this? So this has been discussed in the reference network as well before in one of the sessions, and there were different opinions. So what about the Hind Gut finally? So I come to my conclusions. What about the Hind Gut? I think initially it needs to be safe. You have to try to save it, tubularize it, and use it for fecal diversion. And maybe in the future, you have to think of future reconstruction for the bladder or vagina. That's the initial phase. I think a colostomy is the preferred first step you have to choose if possible. But sometimes the colon, which you will find is not very valid for use for the colostomy. And then an ileostomy, and Thomas said it as well, can be a second best and can be very good as well. But and then finally, a pull through can be done, we think, if there's solid stool, if there's a sufficient pelvic floor, if there are little spinal anomalies. And I think this is, and I can't emphasize it enough, it is a joint decision, not by the surgeon, not by the urologist alone, but everyone together with the patient, with the parents. Finally, if we look at the very long-term outcome, and I think Wout already mentioned some of it as well, how that we treat them lifelong. Garsh has published, I think this year in 2022, a systematic review on 12 studies, and as in most pediatric surgical studies or systematic reviews, there aren't many good studies. But what we do know is that urinary incontinence rate is very high, and it all depends on how you measure it, but it can be up to 85 and 100%. And sexually and fertility issues are an issue. Why do I say this? It's because if you start with to treat these patients, you need a transitional program. You need transitional care. You need adult care. You have to know where to send the patients when they're grown up. And for these, I think, and that's our experience, is that case managers are key to this kind of care from birth, but particularly in this phase, they are the ones coordinating all the care, because taking a multidisciplinary patient into adulthood, it takes even more time to find all these other specialists. Now, in our hospital now, we are lucky that we now just recently started transitional help desk to see how to take care of these patients, particularly if they have multiple morbidity. Thank you very much.
Now, before we end, we have some ideas or some suggestions for the future and the future expectations and innovations. So I think patient participation in current and future activities are key. We need to learn from the adult patients. We need to collect the information, which are all hidden into the electronic or paper files. And we have to share the knowledge and generate new knowledge. This is supported, like I mentioned, by many groups like the EU for Health, financial support, the networks, the patient organizations like EUROGEN, Orphanet, the new research rare disease partnership, expertise mobility programs, and this is all connected together in the future, we think. One of the things is that a registry has been developed and is operational now, in which we think we need the data entry from the common data elements, from the doctor data, but also from the patient data up to 25 years. We need virtual remote consultation options, which are there and which are in place. We need new knowledge, new research and education, and especially training of the new experts of the future. There is a goal for this. There's a vision on this for 2030, and different items are involved, as I mentioned before. The next step, I think, will also be a global collaboration with global networks, especially for rare diseases, where we can, over the globe, collaborate, exchange the information, share the information to the patient or to the experts, reach the care programs which are needed, and maybe cure where possible. I think from our side, the information will be shared from the network, at least to different sources. And again, Ivo and I would like to thank you for your participation, and we're open to answer questions whenever possible. Thank you very much.
Thank you very much for this very detailed presentation. Also, with question was it was in the chat, was from Sonia Perez Bartales to Dr. Boemers, and she was asking, how do you decide to perform a primary versus secondary bowel reconstruction?
Can you hear me?
Yes.
Yes. Well, usually what we did is that we always opted for a pull-through procedure. So we tubularized the cecal plate and we isolated the tail gut, taking care of the vascular supply, and we did a primary pull-through because our experience was that we had a significant number of patients who would become fecally continent through bowel management. However, there is a group of patients where this does not work very well. And so the idea is in the future to maybe look more at spinal deformities and then maybe decide whether or not we would use the cecal plate as a bladder substitute. And that was one of my discussion points. Is an ileostomy always the worst thing you can have? And I think there are many children with cloacal extrophy who are quite happy with an ileostomy. And one of the problems, of course, is that small intestine is also foreshortened. So you always have to be aware that if you use small bowel for bladder reconstruction, that the children might end up having a short bowel syndrome, at least for a few months or years.
Okay, thank you, Thomas. The second question is from Bangladesh. Mitul is asking, that's also, I think, goes to you, how to address urinary continence. So he suggests, what about diversion of the small-sized bladder to the lower rectum rather than closure of the bladder, which will reduce bladder volume, increase upper tract pressure, damaging the kidney. And he's also asking about your follow-up, especially of the upper tract, upper urinary tract.
Well, we always attempt primary bladder closure. However, that's not a continent bladder reconstruction. We close the bladder plates. We get them to the midline, and then we close the bladder plate in an incontinent fashion. So there's a little opening in the genital region where urine flow occurs. And because of that, we do not have to be afraid of the upper tracts at that stage. Our concept is that when the child is around 5 years of age, then we opt for continent reconstruction, which means that we make a neobladder or a bladder augmentation with small intestine, and we form a Monty stoma for intermittent catheterization. And with this, usually we can get all the patients continent. One problem is closure of the bladder neck. I'm a bit concerned sometimes about closing it because then we do not really have an access to the bladder anymore. However, if the children are incontinent, it is because we have not closed the bladder neck. And all children are on follow-up on a regular basis, an ultrasound of the upper tracts, event. Sometimes MAC3 scan are always done in these patients for years until adulthood.
Okay, the next question for Professor Wout, Feitz, and it's from Leipzig. It's about VUR, vesicular ureteric reflux. Do you perform urethral reimplantation during primary bladder reconstruction?
No, like was mentioned, I think it's not, you cannot call it primary bladder reconstruction. It's closure of the bladder plate or bringing them together and finding a safe way out so that you have no risk for the kidneys. Like was mentioned before, there's a balance between continence, bowel, and growth, and renal risk, dialysis and transplantation. So it's very much depending, I think, on the specific patient, how is their renal status, and what risks can you take in relation to the continence reaching. But in primary case, we would not directly operate on the ureters, I think.
Okay. Next question is from Remy Wally, asking about non-surgical issues like hematological or immunological conditions, such as neutropenia. Have you seen those, and is this an issue?
No, but I can imagine that, at least in our series, and I don't see very much in literature about that. They're very they're immunologically disturbed. Of course, having these multiple organs disease, you are prone for I mean, it's clear that you're more prone for infections or other things, but it's not because your immune system is damaged or anything. At least that's what I feel. But I don't know about Thomas, if he has in this series, he has a larger series, if there are any patients with which were immunocompromised, but I don't think so. Or anybody else in the audience, maybe someone from Baltimore or something.
Can you hear me?
Yes.
We have not encountered these entities, no.
Thank you. So the next question is from Annette Lemley. Who of you is involving the gastroenterologist? And if you do it, how do you do it?
Well, for us, we discussed about before. It's estimated about 25% of the patients can have intestinal failure, and this could be more or less, and depends. I mean, if you look at the series, but if you have and the intestinal failure is not only due to the smaller size of the bowel. Sometimes it's a functional short bowel or shortening as well, and this is, you can imagine, the same as with gastroschisis. I mean, the bowel, there is an entrance of fluid during pregnancy. So the bowel is not completely normal. On the other hand, most patients have sufficient small bowel. If you have an ileostomy and functionally shorter bowel, it's easier to get intestinal failure, and those patients do need parenteral nutrition, sometimes for a few years, and additional nutrition if you want to get them off parenteral nutrition, additional enteral nutritional care as well. And I think a gastroenterologist is the one who should be involved. But this is not true for every case. So you have to decide this relatively early, you'll find out, and then you decide whether you need them. But they should be on board, they should know, and they should be in your team somewhere for consultation. That's our experience.
Okay, so next question is on rectal diastasis, on extreme diastasis greater than 6 centimeters. Do you do osteotomy and then gradually crank the pelvis together over time, or what is your approach?
Martin?
Yes, whoever wants to answer. Yes,
just one question. My video is turned off by the host, so
that's no problem. Maybe Gaia can fix this. Yeah, maybe you can start answering.
Well, usually when we operate newborns, we operate within the first, let's say, 48 hours. And in those cases, we do not perform pelvic osteotomy. However, in secondary cases, where we have a wide diastasis of the symphysis, we would, as I said in my lecture, we would do innominate osteotomy in order to be able to close the pelvis. But we do not do it primarily in every child.
Okay.
Okay. The next question is from Dr. Oates-Bay. He asked about your experience with long-term results of gender reassignment in those patients who are already grown up. So the effects of prenatal and perinatal androgen effects on brain and gender development and possible legal issues.
The patients I know, like I said, some are happy, some are less happy. They need consultations, many, of course, from psychology, endocrine, and other reasons. And some, they do not want to disclose this. So once they're stable, they go, I know I talked to Reiner at one of the congresses. We know that patients go to him for which the treating physician does not even know that patients visit him. So this is a very difficult area where not a lot of knowledge is available, let's say this way, at least as far as I know.
Well, in Germany, we have a new law which actually forbids it. So you cannot do a sex reassignment. It is virtually impossible. The other thing which you should always take into consideration is that if you convert a boy into a female, then you have to be consequent and you have to take away his testicles. So you have to do an orchidectomy bilaterally, and this takes him the chance of being fertile later in life. So actually, it's a form of sterilization which you're doing. And I think this is so harmful that I would, how do you say, I would revert from it in any case. There is no substantial evidence that doing this in a newborn boy is of any value later in life. So if he wishes as an adult to have this surgery done, he can always have it and decide by himself. But no doctor, and also not the parents, would take the decision on that.
There's one more question from Sonia Perez asking about when you use the Ilium for bladder augmentation or for a Monty continent stoma, will this worsen the short bowel syndrome? I guess yes, huh? You have less bowel.
Well,
Yes.
of course, yes. That is something which you always have to take into consideration. So if you operate the child, then you have to see how much bowel is left. And you always have to remember these children do not have an ileocecal valve in the normal sense. So when you take small bowel, you have to decide during the operation whether there would be a even slight chance that the child would have a short bowel syndrome. This is also one of the discussion points where I said maybe we should take the cecal plate from the beginning on for bladder reconstruction, and not small bowel only.
I think we should also not forget that there are patients who have both stomas, so ileostoma, colon stoma, and also urinary diversion according to Bricker. And we recently published our 25 years outcome, and if you see the re-operation rate in these patients and the satisfaction, actually the re-operation rate is very low and the satisfaction is quite high if it's done for the right reasons. And patients nowadays can travel all over the world. And there again, a case manager comes into place, because if a patient goes to Australia, it's very helpful if they are known in the stomal care in Australia. So there again, we need global collaborations that patients can travel and have their care which they need.
think we have the last question from Dr. Radim Kochvara. If you have if the patient has intra-abdominal testis, is a Fowler-Stephens procedure feasible given the previous reconstruction?
Yes,
I think it should be feasible, yes. It's a little bit depending on where the testis is lying, of course, but I mean, I think in the boys, I don't, we have no patients at least where it was a real problem, let's say it this way.
but it's feasible, I guess.
So I think it's feasible, yes.
In any case, when you operate a male patient and he has intra-abdominal testis, then you should try to get them into the groin during the first reconstruction, because later on it's going to be very, very difficult. And you have to open the abdomen again. You cannot do laparoscopy in these children. It's, at least in my opinion, it's not possible. So you have to do it during the first surgery. I have a question, if I may, to the panel, and that is concerning the female genital tract. We are putting a lot of effort in reconstructing the, I'll call it the Mullerian structures. And in many cases, we try to do a neovagina, either with short bowel or sometimes with large bowel. However, our experience is these neovaginas do not work. And I'm not aware if there's any case of a woman with cloacal extrophy who gave birth to a child. And now, after many years operating these children, treating these children, I have, of course, adult female patients who want to have children of their own. And I send them to infertility clinics, and it's an absolute problem to harvest egg cells, and in the other case to implant the cells into a womb. So it seems to be something which is impossible. And so I think we should also in the next years maybe look at this aspect, whether it is whether we should do reconstruction of the female genital tract.
Well, it's depending, I guess, on the surgical options you have. That's one. We know that there can be a lot of problems with these bowel reconstruction on vagina and uterus connection. And I know patients who have an abnormal position of their ovaries in the abdomen. So these are all factors, I think, which play a role in this. And they might have an abnormal uterus. So yes, I agree. These discussions will come. You have to be prepared on this, and you need experts from that area where you can send the patients, where they understand what the origin of the disease is, and how and if they can have their wishes fulfilled. Let's say it this way. It's not always possible, I think.
And considering the vaginal replacement in the early surgery, I know in our series there's two cases, I think, with vaginal agenesis. They didn't have a primary reconstruction. They were thought they should think about it when they grow older. They are older, but both of them don't want any reconstruction. They're happy with the way it is. So we as surgeons try always, particularly at birth or at the first surgery, think, okay, we have to do things in advance and think for them or think for the parents what is best. But sometimes just waiting for it, and other options in adulthood are possible as well. And our gynecologists are, for example, clearly not in favor of intestinal replacement of the vagina because of all the difficulties they have in adult life as well. And they prefer it not to have it than to have it. So, and I'm not saying that one or the other choice is the real truth. I think you have to think for yourself what is good, and talking about it like this is good to know. That's why we do need more collaboration in this issue, so form some kind of a group, a global group with experience of patients and people who treat these patients. So,
but could you clarify again? Thomas had in his talk preservation of the uterus with a question mark. So has the uterus to be preserved at all means? Yes or no?
well, I wouldn't throw it away. I agree with Tom. I agree with Thomas, not in all cases, but I wouldn't, same as the colon, I wouldn't throw it away at just because we think in the future it's not useful anymore. It's good to think about it. And if it's rudimentary, if everything is rudimentary, then you can consider it. But these are very difficult decisions. And I think, again, you have to decide it together with more people and think about it.
I think you should not throw it away because we don't know what developments are made in medicine. Maybe somebody takes a rudimentary uterus and does some tissue engineering and creates a beautiful uterus in 30 years or something.
A small remark, maybe on this, just an answer.
Maybe a Dutch person invented.
No, the conclusion
Very
of
unlikely, but maybe.
But the conclusion of our paper in 2014 or 15 was that the future will be regenerative medicine. We are 8 years on the line, and regenerative medicine is not going at such a speed. And I know about 30 years, but and we are working on it in the lab as well. But it's not as easy. Again, but I agree. Don't throw it away.
I agree because this is what I've been doing over the past years. However, if you keep the uterus, you have to know that the girls, they will menstruate, and the menstruation blood has to go somewhere. So you have to create some kind of channel, either neovagina or something, a conduit, where the menstruation blood can flow to, because otherwise the children have not only pain and a lot of problems, they can develop endometriosis, which is even worse for many children. So this is a big issue, to be honest, and we can probably only answer it in the next years when we have enough follow-up for older women with cloacal extrophy.
Great. I think this is great final words. We need to close the session because we are not over the hour. We are over the 1.5 hours, but still 122 participants have stayed with us. Thank you, all the speakers. Thank you, all the participants online watching this webinar. As I said in the beginning, we will edit it and then put it on the YouTube channel. I put the channel address in the chat. And our next webinar will then be
April 13th.
April the 13th. Yeah, management of recurrent TF, but not only surgery, but how to manage it endoscopically with chemocauterization or thoracoscopically. And I think these two options are far better than going in there in an open fashion. So I think I will really, you should look forward to this webinar, the next one. So yeah, thank you also, Gaia, for setting this up. Gaia is in the lower end of the chat. She's not only the queen of social media, but Gaia, we love you all. And I'm sure the next webinar will be a success if you organize it again. And also, finally, I think it was a great idea to collaborate with eUROGEN. So when we join the forces with EUPSA and eUROGEN and all the experts in the field, no matter where they come from, we will move forward with these diseases. Okay.
Hey, can I just say
Augusto.
Yeah, thank you, everyone. Incredible attendance today. We have several countries, as I said at the beginning, but far more than usual. And we'll capture this. This is incredible. It goes well beyond the borders of Europe. And EUPSA is indeed an international society. So what puts us all together, makes us all, friends and colleagues is for in the end for the benefit of the child. And when it comes to these complex cases, having the experts and experts also attendees that can ask relevant questions is really terrific. So thanks everyone, and look forward to the next one in a month's time.